Hello everyone, this is Sandeep Sharma here. A lot of you have requested me to make a quick review of Rickets so that you can wrap up or revise the topic in 10 minutes or so. So this is a small video. Remember, I'm only talking about the important key points you are supposed to know about Rickets. So let's begin the discussion. What is rickets? Rickets is a nutritional disease which is characterized by defective mineralization of the growing long bones. You need to understand that rickets is a disease of children. See, vitamin D deficiency, calcium deficiency can occur at any age. And when bone density is decreased, there is defective mineralization at older age, then we call it as osteomalacia. Rickets occurs only in growing bones. So beyond 18 years of age, vitamin D deficiency will not produce rickets, it will produce osteomalacia. Osteomalacia is characterized by defective mineralization leading to decreased bone density. So rickets includes kind of osteomalacia, although the term osteomalacia is not very commonly used in children. Osteomalacia is preferred in adults, but technically speaking osteomalacia can occur at any age, whereas rickets occurs only in children. Often there is a confusing term you will find, osteoporosis. Remember that osteoporosis is generalized bone volume. The matrix as well as the mineral part is affected. Now to understand that, just go back into the basics and try to think. A bone basically has two parts. What are the two parts? One is osteoid matrix, which is composed of the extracellular substances, collagen fibers, and mucopolysaccharides, etc. That is the matrix part. Matrix के अंदर there is deposition of minerals, what we call as hydroxyapatite, calcium and phosphorus minerals. So there are basically two components of bone. One is the osteoid part, the matrix part, which is proteinaceous, and second is the mineral part. Now, there are two deficiency diseases if you remember. One is rickets, second is scurvy. In scurvy, due to vitamin C deficiency, the osteoid matrix part is affected, but mineralization is normal. Whereas in rickets, the matrix part is normal. The collagen fibrils, they are normal, but defective mineralization is seen. Old NEET MCQ. What is the primary disease process in rickets? Four options were given. The correct answer was defective mineralization is the basis of rickets. So it is a disease of growing long bones. Another related MCQ. Can kwashiorkor and marasmus show rickets? Yes, they may have rickets, but the radiological features and clinical features may be absent. Why they are absent? Because rickets is the disease of growing bones. In severe malnutrition, you will find that the growth is not happening. And so despite rickets being there, it will not manifest itself. In fact, many times when you treat kwashiorkor and marasmus, the clinical signs of rickets become apparent. Not because vitamin D deficiency has happened, but because now the growth has started and so the clinical manifestations have started appearing. So what are the three things you need to remember? One, rickets occurs in children. Second, there is defective mineralization. And number three, it is a disease of growing long bones. Why do these bony deformities happen? Let's look at the pathophysiology. This is a handmade diagram I have made. There are other diagrams also I could have copied from various textbooks, but this is the kind of diagram which always is easy to relate. So we have epiphysis, we have metaphyseal growth plate, and we have the diaphysis. Okay, look at the metaphyseal growth plate. Metaphyseal growth plate, you can find that there are basically 5 zones. What are the 5 zones? The part which is towards epiphysis is known as the resting cartilage zone. It is only 1 to 2 cell layer thick. The cells are not densely packed and they are primarily composed of chondroblast, which are differentiating into chondrocytes. Stage 2, the zone 2 is your proliferating cartilage zone. Now the cartilage zone 1 say lot of cells are dividing, lot of cartilaginous cells are dividing. They are active, they are living, and they are densely packed together. That is the zone 2. Then in zone 3, as you come towards diaphysis, you find that these cartilage cells, those who had formed earlier, now they start getting hypertrophied. So whenever their size, volume increases, but they are still living, that is hypertrophy. Stage 4 or zone 4 is the point where actually rickets affects. So if somebody asks you what is the site of affection, it is the necrosis and mineralization zone. What actually happens is Under the effect of various hormones, including parathyroid hormone and various other growth factors, which are not beyond our discussion, there is accumulation of phosphorus in the cartilaginous cells. These cartilaginous cells, when phosphate enters them, they start undergoing apoptosis. So necrosis and apoptosis occurs due to phosphate accumulation. So necrosis, although the term is mentioned necrosis, it is actually apoptosis which is happening here. So necrosis and apoptosis occurs due to phosphate, and when these cells die, they are filled with hydroxyapatite. That is why it is also known as the mineralization zone. So this dense zone, zone 4, which I have shown, is the mineralization zone. And zone 5 is the ossified zone, where the dead cartilaginous cells are progressively replaced by osteoblasts coming, depositing the cells, and the bone tends to grow. So this is how the bone process grows. Now imagine a scenario where phosphate is deficient or there is a defective vitamin D levels. What will happen? It is zone 4 which will be affected. The cells will not have adequate mineralization, and the density of the bone, the zone 5 which is developing, that will not develop properly. What it will lead to? There will be cupping, splaying, flaying, and widening of the growth plate when weight bearing happens. This is why deformities are produced. So this biochemical nature is important. You may get even a visual question based upon that. And if you are a resident, again, this topic is sometimes asked. When I was a resident, I got a case of rickets in my MD. So this thing was asked to me in my Viva as well. And it is important for your entrance exams also. So this is the pathophysiology, why bony deformities tend to occur in rickets. What are the causes of rickets? Vitamin D disorders are the overall most common group. Among them, the single most common cause is nutritional vitamin D deficiency. There are other causes like congenital vitamin D deficiency, malabsorption, decreased liver 25 hydroxylase, vitamin D dependent rickets type 1 and 2, and chronic kidney disease. We have calcium deficiency leading to dietary deficiency. There is a prematurity of rickets, which is seen in premature children, and malabsorption. Phosphate deficiency can occur due to dietary phosphate deficiency. It can occur in premature children, and aluminium abuse, aluminium antacid ka overuse can produce phosphate deficiency. It is a statement-based question asked in PGI exam. Old, of course, PGI question, but can be asked in NEET entrance as well. And then we have the renal losses, which includes the rare forms like X-linked hypophosphatemic rickets, rare forms distal RTA, McCune-Albright syndrome, Dent disease, and the Fanconi syndrome. If somebody asks tumor-induced rickets or tumoral calcinosis rickets, that will also be included in the renal losses. So these are the causes. Overall most common cause, nutritional vitamin D deficiency. Moving to clinical features, the first sign is craniotabes, which is seen at 6 months of age. Craniotabes is ping pong ball sensation. You press a ping pong ball or a table tennis ball, it gets depressed. You press from the side, it pops up normally. So if you have played table tennis, the consistency of the skull becomes like that of a table tennis ball. We call it as craniotabes. It is better felt than seen, first to appear at 6 months of age. What are the signs which appear between 6 months to 1 year? There is frontal bossing. There is frontal bossing, prominence of the frontal bone and the parietal bone. Rachitic rosary, which is beading of the ribs. Harrison sulcus. Harrison sulcus is a transverse horizontal line which is produced on the anterior chest due to diaphragm pulling on the weakened ribs. And widening of the wrist. Widened wrist begins when the child starts crawling and creeping. So there is pressure on the wrist and there is cupping, splaying, and fraying, leading to widening of the wrist. Point to remember, what is not seen in rickets in infancy? Bowing of legs is not seen. This is again your NEET MCQ. Because bowing of leg will occur once weight bearing begins, and that will not be seen in infancy. So above 1 year of age, you will find double malleoli, that is splitting of the malleoli into two. Delayed dentition. What is delayed dentition? Somebody can ask you. Absence of onset of dentition beyond 13 months of age is delayed dentition. Then delayed closure of anterior fontanelle. Normally it closes at between 18 to 24 months, but it can persist beyond 2 years of age. Bowing of legs and or knock knee may be seen. Now, one is genu verum, second is genu valgum. Please do not get confused. Bowing of legs is known as verum. Knock knee is known as valgum. How to distinguish between the two? I'll be showing you a picture. And the other features can be seen, which include Pectus carinatum, that is pigeon-shaped chest, there is forward protrusion of the sternum, failure to thrive, pot belly, visceroptosis, that is, what is visceroptosis? The mesentery becomes weakened. So if in a standing or a sitting position, if you try to check for liver and spleen, you will find the liver and spleen are palpable. You make the child lie down, then in a supine position, you check for liver and spleen size, they come to be normal. So what is visceroptosis? That is downward displacement of the intra-abdominal organs, that is known as visceroptosis. There is increased risk of fractures, there is proximal myopathy, and dilated cardiomyopathy may occur due to hypocalcemia, and seizures may also be seen. Seizure word has been hidden due to this window. And finally, vertebral anomalies including kyphosis, scoliosis, and exaggerated lumbar lordosis may be seen. So what are the features? On this extreme left, you can see the widening of the wrist. There is pectus carinatum, as you can see in this child. Then you have the knock knee and the bowed legs. In bowing of the legs, the knees are far apart, but the ankle joints are close. Whereas in knock knee, the knees are rubbing against each other, but the ankle joints are abnormally large. And sometimes, rarely, wind-swept deformity will be seen. Wind-swept deformity can be seen in multiple conditions. In adults, it can be seen in rheumatoid arthritis. But in children, the most common cause of wind-swept deformity is rickets. Why will wind-swept deformity occurs? It occurs due to combination of verum and valgum. So one limb is showing verum, second is showing valgum, as you can see in this child. That is producing a wind-swept deformity. Pectus carinatum and excavatum are separate things. Carinatum may sternum, chest is protruding ahead. Excavatum, it is depressed inside. Excavatum is a rare feature of rickets. Carinatum is a more common feature of rickets, but it tends to occur in older children. Moving to radiology, these are the radiological signs. Most commonly, we do the X-ray of the wrist joint. Sometimes knee joint is also done. Features include: first change, there is loss of normal provisional zone of calcification at the metaphysis. Fraying comes before cupping or splaying. What is fraying? As you can see in this picture, look at this picture. Can you see there is indistinct or irregular margins which are being formed? That zony kind of thing, that is known as fraying of metaphysis. Point to remember, fraying comes before cupping or splaying. Although the overall first common sign is loss of provisional zone of calcification. Cupping is concavity in the metaphysis, as you can see in this picture. And splaying, that is due to pressure, the bone tends to move laterally. That is known as widening at the metaphyseal end. As you can see in this picture, the widening is occurring and the lateral aspects. The widening is happening here. This is the part where splaying is happening. Splaying is happening, and this white arrow is your cupping. So these are the radiological signs. Overall, osteopenia, that is decreased bone density, may also be seen. Moving to investigations in vitamin D deficiency rickets. Serum calcium will be normal to low. Serum phosphate is low. Alkaline phosphatase is high. Remember, alkaline phosphatase is always high in all types of rickets. Serum PTH is high, parathyroid hormone, and serum 25 hydroxy vitamin D levels. Below 10 is deficient, below 20 is considered insufficient. Usually 20 to 60 is considered to be normal, 60 to 90 is considered to be high, above 90 is considered to be toxic levels of vitamin D in the blood. So you will find low 25 hydroxy. Remember, 25 hydroxy vitamin D levels are better marker than 125 DHCC, because 125, that is the activated form of vitamin D, can show false positive, false negative results in vitamin D deficiency. So if somebody asks you which is a better test, you only do 25 hydroxy vitamin D levels. Moving to differential diagnosis, this is the table you must remember, you must cram it up, which is showing the common types of rickets. What are the calcium, phosphorus, alkaline phosphatase, PTH, and 125 DHCC values in them. Moving to treatment of vitamin D deficient rickets. The commonly used, the older one, STOS regime. STOS regime may we give 60,000 international unit daily orally. If not possible, you can give intramuscularly for 10 days. Total dose to be given is 6 lakh international unit along with calcium in the given dose. But the new regime says, there is no name of this regime. The regime simply says you give daily dose for 12 weeks. In a lower dose, 3,000 to 6,000 international unit daily for 12 weeks. In age below 1 year, the dose should be reduced to 2,000 international unit per day. After that, you give a vitamin D maintenance dose. Maintenance dose of vitamin D is 400 to 600 international units. and oral calcium is given in the same dose as well. So any of the two regimes can be used. In my practice, I use both of them depending upon the patient, depending upon compliance. Talking about healing, radiological evidence of healing appears within 4 weeks of starting the therapy. Healing line at wrist appears, which is the first sign of healing. Clinical and blood investigation takes time. If there is no response to 2 megadoses, that is 2 times regimes have been completed, you have to consider refractory rickets. So what is refractory rickets? The approach is very important. You will find difficult MQs on this. So this is the approach which I have formed in a slightly twisted form from what you have seen in OP Ghai and different books. The red tables are showing you the clinical findings, the diagnosis. So any child who does not respond to 2 doses of ricket, 2 doses of vitamin D, you will first do, what is the first investigation to do? You will do a serum phosphate level. If it is high, you will think of chronic renal failure. If it is normal to low, you will do a blood pH. If blood pH shows acidosis, metabolic acidosis will show renal tubular acidosis. If it is normal, then you proceed for calcium and PTH levels. If calcium and PTH levels are normal, you would think of X-linked hypophosphatemic rickets. So low phosphate, normal to low phosphate with normal PTH is a feature of X-linked hypophosphatemic rickets. However, if PTH is high, you will think of vitamin D dependent rickets, and vitamin D dependent rickets is of 2 types. If there is low activated form of vitamin D, you call it as type 1. If it is high activated form of vitamin D, we call it as type 2. Please make this chart 2 or 3 times for practice before you go to the exam. This is a very popular chart for examiners when they frame MCQs. Now talking about some one-liners. X-linked hypophosphatemic rickets. Among genetic disorders causing rickets, it is the most common with a prevalence of 1 in 20,000. Defective gene is on X chromosome. It shows X-linked dominant inheritance. That is very important. There are very few conditions which are X-linked dominant. One is X-linked hypophosphatemic rickets. Another is Rett syndrome. Third is your Alport syndrome. And there are a few others. The defective gene is called FEX because it is a phosphate regulating gene with homology to endopeptidases on the X chromosome. The FEX protein regulates a protein known as FGF23. In FEX mutation, there is overactivity of FGF2, which leads to decreased 1-alpha hydroxylation, decreased phosphate reabsorption, producing the disease. So decreased phosphate reabsorption means the patient will have low phosphate levels. And since it is occurring independent of PTH levels, so PTH levels would be not affected. So what clinically will happen? These patients will have features of rickets, but they will not show response to your usual vitamin D. Patients will have high renal excretion leading to low phosphate. They will have high alkaline phosphatase. PTH and serum calcium are usually normal. They are inappropriately normal. And these patients are also found to have low or inappropriately normal levels of 125 DHCC. It is called as a paradoxical reaction. Why it happens? Again, you can go deep into it if you are preparing for the next exam. If you're sitting in another 10 days, stick to just remembering the values. Nobody asks details even in NEET super specialty exams. So treatment, patients respond well to a combination of oral phosphorus and calcitriol. Potential MCQ, new monoclonal antibody directed against FGF23, burosumab TWZA Twaza has been approved for use in children above 1 year of age. So it is a new drug, can be asked in entrance exam, not mentioned in Ghai, mentioned in new Nelson. And then we have 2 types of vitamin D dependent rickets. Both of them show autosomal recessive inheritance, type 1, type 2. Type 1, there is genetic deficiency of 1-alpha hydroxylase. Type 2, there is end organ resistance to 125 DHCC. How do you differentiate? With type 1 has reduced 125 DHCC levels, whereas vitamin D dependent rickets type 2 has raised 125 DHCC levels. Both of them will show rickets. And additional finding, which is a potential MCQ if I'm an examiner, type 2 rickets will be showing some additional abnormalities, alopecia, dental abnormalities like endodontia and ectodermal defects, whereas no systemic findings other than rickets are found in type 1. Treatment of type 1, calcitriol with calcium and phosphorus. Type 2 treatment is difficult. Most of these children tend to develop the so-called brittle rickets where the management is difficult. So this is the brief synopsis of what you need to know. I have gone through the previous papers and all MCQs which have been asked so far I have tried to cover in these slides. Go through it once, twice, thrice, wherever you feel like, stop, make notes, but revise it at least once before you sit for your exams. So this is Sandeep Sharma signing off. Thank you very much and keep preparing for your exams. Thank you.